Good morning. Good morning. And welcome to the Town Hall on the One Big Beautiful Bill, what it means for Louisiana's families, health, and future. Thank you for joining us this morning for this occasion. We have an outstanding panel of subject experts here that you will hear from shortly. I am Alma Stewart Allen, the president and founder of the Louisiana Center for Health Equity. We are a nonpartisan, nonprofit organization that is based in Baton Rouge, Louisiana. However, we are a statewide organization serving the state of Louisiana. I want to just recognize our chair, Ms. Diane Hargrove Robertson, who has been the lead in organizing this. It was and is her vision to do this town hall. At this time, it is my pleasure and an honor to introduce and turn you over to our Mistress of Ceremonies for the hour. And she is Miss Asali DeVan Ecclesiastes. Just like in the Bible, Ecclesiastes. And so Asali is an educator, organizer, and author. She is a performer. She's a community leader rooted in New Orleans in the indigenous culture. She serves as executive director of Ashe Cultural Arts Center, and if you have a chance to stop by and visit them, I'm sure they would welcome you, and it will be an experience all in of itself. She is the Chief Executive Director, also or Officer of Efforts of Grace Incorporated, leading cultural and community development initiatives. She previously directed strategic initiatives and development for the New Orleans Business Alliance and also the Mayor's Office, designing equitable programs that empower resident leaders. She's a Tulane Mellon Fellow and author of 2 TED presentations. Asali has received national and local honors, including President Obama's Drum Major for Service Award and Essence Magazine's Excellence in Service Award. And she is also a Delta Sigma Theta. So join me in welcoming our Mistress of the Hour. Thank you so much.
Thank you all so much for the honor of curating and leading us in this conversation. Before we get started, I would like to ask Marcela Thomas, the Assistant Chaplain for Dillard University, to join us or to lead us in our invocation, please.
Hello. Thank you. Good morning, everyone. On behalf of Dillard University Center of Racial Justice, I welcome you to this gathering in Lawless Memorial Chapel. This is not only a place of worship, but a place to also practice history. In this very chapel, Dr. Martin Luther King addressed a group of Dillard students at a baccalaureate. His words called the generation to courageous and to serve, and today we honor that same legacy. We are called to continue the works. As people shaped by justice and love, we are called to speak for those whose voices are ignored, to advocate for people that can't advocate for themselves, and to ensure that policies and practices reflect dignity for all. Today's town hall is more than a meeting about health and equality. It is a continuation of struggles for freedom, for fairness, for compassion, that our leaders have carried forward in this very space. Let us pray. God of justice and love, we pause with gratitude for this day and for the legacy that surrounds us in this chapel. As Dr. King reminded us, we are tied together in a single garment of destiny. Strengthen us now to carry forward the vision. Bless every speaker, bless every partner, every plan formed here. Make our minds sharp with wisdom and our hearts steady with courage, and our spirits open to collaboration. May we leave this place with committed to justice, more rooted in love, and more faithful to the call to serve all. We ask this in your holy name. Amen.
Thank you so much. So y'all might be asking yourself, what does a cultural practitioner and somebody who leads cultural organization have to do with health and health equity? Well, I want to tell you that it is at the core of our culture. It is at the core of who we are. When we talk about culture, we generally tend to think about the arts and entertainment, but I want to tell you that how we take care of ourselves and how we create wellness all around us is at the core of cultural competency. And so I'm so honored to be able to have this conversation today. And we're gonna start it with a very important presentation because I don't know about y'all, but when I heard about the big, beautiful bill, well, one, I knew it was gonna be big, but two, I knew it wasn't gonna be beautiful because I'm well versed in the cultural competencies of this nation, right? And I know that with the current political climate we're in, doublespeak is something that I only thought I'd read about in 1984, but now we're living it. But fortunately, we know how to translate it, and we have people who are committed to helping us to navigate our way through these issues. And so I would like to introduce at this time Christina Piecora. Christina Piecora is a senior policy analyst at the National Health Law Program, founded in 1969 to protect and advance health rights of low-income and underserved individuals and families. Can we give an amen for that work? They advocate, educate, and litigate at the federal and state levels to advance health and civil rights in the U.S. They are a force in the courtroom. I love that as a description. They are a force in the courtroom working to ensure that low-income people and underserved communities can obtain quality care to which they are legally entitled and holding state and federal Medicaid agencies accountable for their programs. Before joining as the senior policy analyst, Christina worked as a consultant helping advocacy groups advance reproductive health, rights, and justice. Her biggest client was the National Institute for Reproductive Health, where she conducted legislative reproductive rights legislation. She was also responsible for tracking legislation and compiling data for NIRH's influential annual Gaining Ground report. Please welcome Ms. Christina Piecora to the stage, along with Mr. Anthony Wright. Mr. Wright is the executive director of Families USA. Before joining that organization, he served 22 years as Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. Under his great leadership, they led state efforts to win patient protections, fight budget cuts, invest in the safety net, expand coverage, and advance equity and prevention. He led California's coalition to help pass and later defend the Affordable Care Act and for state policies to implement and improve the law to attain the biggest drop of uninsured rate in the nation. He was responsible for numerous successful healthcare advocacy efforts to pass critical health reforms. And I can't think of two better people to lead us through the big and beautiful bill. Thank y'all so much.
Good morning. Great to be here. Again, I'm Anthony Wright, Executive Director of Families USA.
I am Christina Piecora. My pronouns are she and her, and I'm a Senior Policy Analyst at the National Health Law Program.
And we are delighted to be here today. Both of our organizations work closely together, and we decided rather than do two separate applications, there's a lot to go into with regard to this bill, so we decided to do our presentations together. So we'll be doing this a little bit tag team to get into it. And you have a great panel afterwards, but we wanted to give you some foundation of everything that's in the bill. And so we'll do that for the next about half an hour to do that. But we have the slides, but we're going to introduce our organizations first.
Honestly, we were pretty much already got the most awesome introduction, so I think we can skip on over if you're okay with that,
Yes.
Anthony.
And then Families USA as well.
You're good?
And do you want, okay. No, go ahead.
Okay. Just a disclaimer, as Anthony said, this law is huge. It's over 900 pages. There's a lot in it. We're just giving a broad overview today, mostly focused on Medicaid and marketplace cuts. Just a legal disclaimer, we are not providing legal advice, nor can we provide legal advice to you about how your specific organization should respond to this law. And just a note, throughout the presentation, I'll call it the law, I'll call it OBA, I call it HR 1, referring to the same thing, the terribly named One Big Beautiful Bill.
So with that, let me just give you the headlines, which is about the major impacts that this bill, HR 1, would have to coverage, to costs, to care, and to our communities. And just to give you the top line findings, it has a dramatic and negative impacts in each of these areas. Estimated nationally, about 15 million people will be pushed or priced out of coverage as a result of this bill. We will see increased premiums and increased costs, even in Medicaid. We will see significant cuts at both the federal level and to states to providers that we care about, that care for us, whether they be hospitals or clinics or nursing homes or otherwise. And it has specific impact on specific communities, particularly on whether it's rural communities or whether it's immigrants or whether it's women and their sexual and reproductive health. And so we'll go into that as well with a focus, of course, on the impacts here in Louisiana. And again, we'll have an all-star panel to go more into that. So our goal here is to give you that broad overview in those areas of coverage, costs, care, and community. But also, just to be clear, to ground the impacts here in Louisiana, but also give you some specific actions that you can do to try to both document and mitigate these harms and make a change. So that's our desire for this presentation.
Okay, so just a level setting. I know everyone here today understands the importance of Medicaid, but I think it's worth uplifting just how critical Medicaid is. Medicaid is a joint state-federal partnership, meaning that the federal government supports states by providing funds for Medicaid, and states are allowed to then run their state programs. Currently, 72 million people in the United States are enrolled in Medicaid. That's including 19% of adult women. 1 in 5 people in total in the United States is on Medicaid, including 4 in 10 children. And almost half of the adults living in poverty in the United States are on Medicaid. And because of the structural barriers to wealth, as well as systemic oppression, we know that Medicaid covers a higher percentage of people of color and people with disabilities. Medicaid is also by far the biggest source of family planning coverage in the United States. It accounts for 75% of public expenditures on family planning, and it's also the largest payer of births in the United States, covering 41% of births and more than 2/3 among Black and Indigenous people. As Anthony said, but again, it's worth reiterating, this law will cut almost $1 trillion from Medicaid over the next decade. It really is unprecedented. We have not seen a cut like this ever. Up to 10 million people, or at least 10 million people, will lose Medicaid coverage, and up to at least 15 million will lose coverage overall, with additional marketplace changes. I think it bears repeating again and uplifting throughout this presentation. You will see the harm to specific communities. We know that because it targets Medicaid, it automatically targets people with low incomes. In addition to that, there are specific provisions within this law that target immigrants, that target sexual and reproductive health providers and those seeking family planning care. It targets Medicaid expansion states like Louisiana, and it targets, of course, and unfortunately, people of color.
And one thing that it specifically does is targets Louisiana. Louisiana is the state with the highest percentage of people who depend on Medicaid coverage out of all 50 states. You all have beat out New Mexico, You all have beat out California. You all have beat out other states. And through some of that, it's the good work of folks in this room who worked for that Medicaid expansion that was able to get a lot more people covered as a result of your good work. And as a result, people took advantage of that benefit. And so about 40% of the population in Louisiana depends on Medicaid coverage. So when you see the biggest cut in the history of the Medicaid program, that affects disproportionately the state that has the most number of the most percentage of people with Medicaid coverage, about 40%. And the projection is that of that, say, 1.8 million people out of the 4.5 million people in Louisiana that are in Medicaid, the estimates are that over 300,000 folks would lose Medicaid coverage as a result of the impacts of this bill. 300,000 people just in Louisiana. And then obviously we pointed out some of the parishes that are particularly impacted, and that gives you a little bit of sense of where this will be most concentrated. Also, let's not forget that for most of our presentation, we'll be talking about the impacts to Medicaid, since that's the bulk of the cut, nearly $950 billion, nearly $1 trillion, but also the impact on the marketplaces, the healthcare.gov, where a lot of people who have a little bit more income need to go to buy coverage as individuals, and there's also going to be some significant impacts there. And again, in Louisiana, about 300,000 folks depend on that affordability assistance, and many of them will see spiking premiums as a result of what this bill does and does not do. But we'll get to that in a second. Let's get to the work of coverage. Let's focus in on coverage. And again, there's a range of things in this bill that are designed to push and price people out of coverage, particularly with regard to bureaucratic barriers, making additional paperwork to make it harder to get on and stay on coverage. And Christina will go into some of the big ways that do it, starting with these new work reporting requirements.
Yes, thank you, Anthony. Anthony summed it up great. There are a lot of bureaucracy and red tape that's just going to make it harder for people to enroll and stay enrolled in Medicaid. And as I said at the outset, this is one of the provisions that targets Medicaid expansion enrollees. And I just want to go back and uplift, because I know some people might not be familiar. I know Louisiana did great work in getting Medicaid expansion passed. But when I talk about Medicaid expansion, I'm talking about what was created under the Affordable Care Act. They created a new group that was eligible for Medicaid. And because of it, over 40 states, including Louisiana, have adopted Medicaid expansion at this point. And it covers a whole host of disabled folks, people with low incomes, of caregivers, parents, children, etc. It has been a boon. It has given people more access to care, is responsible for helping to lower maternal health inequities and lower the maternal mortality rate. It has helped close the gap and help us overcome some of the HIV epidemic we're seeing. It really is a game changer, and it's responsible for so much good. And this law really targets Medicaid expansion. And one of the ways it does so, and the way that's going to cause the most people to lose health care, is through work requirements, or what proponents of this law have called community engagement. This is the most punishing provision of work requirements we have ever seen. It applies to Medicaid enrollees who are enrolled through the adult ACA expansion who are aged 19 to 64. Those enrollees have to prove 80 hours of community engagement, meaning any combination of work, community activities, part-time school, community service, or they must prove an exemption, or they must prove that they have a monthly income that is equivalent to at least the minimum wage of 80 hours. This is so difficult. And one of the reasons is because of the paperwork and the verifications that this requires. In addition to the actual work requirement itself, states can have to instill a look-back period of at least 1 month and up to 3 months at the discretion of the state, meaning that someone applying for Medicaid expansion has to show that they were already complying with this at least 1 month before application. It also requires states to use data matching where possible in order to verify whether individuals are meeting the requirement and the qualifications. And a really punishing part of this is that individuals who lose or denied Medicaid due to work requirements are locked out of marketplace subsidies. So it cuts them off from any kind of affordable health care in this country. And also, this is going to happen relatively quickly. States must implement work requirements by January of 2027 or earlier at the state's discretion. Now, states can apply for a one-time extension, provided that they're showing that they're making a good faith effort towards implementation. And that's at the discretion of the Secretary. But by January 1st of 2029, all states must come into compliance for their expansion enrollees. I want to be clear. Penalties related to work requirements are just Medicaid cuts by another name. It's a bureaucratic tactic to kick people off of Medicaid. Expansion individuals will lose Medicaid due to red tape, not because they do not qualify or not because they aren't working. Decades of research and evidence show that work requirements do not increase employment, but instead lead to mass disenrollment. Most working age Medicaid folks who can work do work already. Now, there are specific exemptions and carve-outs, but we know exemptions don't work. There are exemptions for caregivers with dependents age 13 and under, for people who are pregnant or eligible to receive postpartum coverage, for quote-unquote medically frail, that is the wording of the law, not my own, and a few others. Now, it remains to be seen how much CMS will be involved in defining what these exemptions are and how much they will leave to the states. But exemptions themselves are cumbersome. Proving you are eligible for an exemption is difficult. And because, like I said in the previous slide, that this is happening so quickly, states are not going to have a lot of time to implement processes that are appropriate for people to access. One, it's super expensive to implement these processes. And two, they're just working in a really tight time frame. So we know that everyone who is exempt will not actually be able to access that exemption. And while the law does contain this list of exemptions, we've seen this fail before. You know, I like to point to the example of Arkansas. They had a really broad definition of disability. But despite that, because the processes and the notices were so inadequate, they had a website that, like, for some reason would close down at 9 p.m. So if you worked and then tried to apply, you couldn't go home and apply on the website. And because of that, in Arkansas, work requirements led to the disenrollment of more than 18,000 adults over just 7 months. Same thing happened when there was a work requirement for Medicaid expansion enrollees in Georgia. After 20 months, only 7,000 adults out of an original projected pool of 345,000 eligible individuals had enrolled. And these requirements are expensive. They waste money on needless systems and bureaucracy instead of putting that towards the health care for state citizens.
And just to underline, the vast majority of people who will be impacted this are already working. These are people who are working and they are just getting caught up in the bureaucratic paperwork that we're imposing for the purpose of having people fall off coverage. And so that's what we're dealing with here. And the examples in Arkansas and in Georgia are that the people who fell off, they were working or they had an exemption because they were, you know, a caregiver, they were in school, they were a person with a disability, and that's the real pernicious part of this effort. And that's not the only bureaucratic barrier as well.
Yeah, and I'll also just highlight, you know, what the work requirements, what Medicaid expansion helped do is really it caught a lot of people in the gap. A lot of part-time workers or seasonal workers, a lot of folks, you know, I know we have obviously a lot of musicians here who couldn't quite make the income eligibility for Medicaid, but then once Medicaid expansion happened, were able to meet that. And work requirements are targeting it only applies to that expansion group, and unfortunately the progress we have seen with Medicaid expansion might be rolled back. Some other bureaucracy to eligibility and enrollment, we've spoken about, but there will be 6-month redeterminations for Medicaid expansion enrollees instead of the required every 12 months as is happening now. The law also cuts retroactive eligibility. So for those applying for Medicaid expansion, it'll cut it down to 1 month. For all other Medicaid enrollees, it'll cut it to 2 months. And Medicaid expansion and retroactive eligibility really is so that when people have the sudden onset of an illness, they don't have to worry about applying for Medicaid in the moment. Medicaid applications are expensive. They're complicated. As recently as June of 2024, CMS had noted that retroactive eligibility protects low-income individuals from medical debt and mitigates adverse health incomes while ensuring the financial stability of social safety net providers, including rural hospitals. Without this retroactive coverage, individuals will most likely either incur significant medical debt or they will put off care until a much later point in time.
Okay. And then I also want to make a point that all these bureaucratic barriers that exist in Medicaid, they also exist in the marketplaces. So again, if you're at or around or just above the poverty level, and again, with the Medicaid expansion that Louisiana adopted, it's regardless of whether you're a kid or a parent or even somebody without a kid at home, you have access to Medicaid and Medicaid coverage. And again, I mean, let's also be real. Even if if the real goal was to get people to work, sometimes actually getting you health coverage is actually the thing that helps you get ready to go to work. To get, whether it's substance abuse or just a treatment, or whether it's just to have a gap between jobs so that you can be covered while you're trying to figure out your next part of life. But for those people who are just over that threshold, then you go and buy coverage in the marketplaces in healthcare.gov. And there you'll be buying private coverage, but with a tax credit that helps you helps you better afford that coverage. But getting onto the marketplace takes some work. There's some bureaucracy involved, and this also imposes greater burdens there. The biggest one is that it gets rid of automatic renewal, so that if you get coverage at your work, if you, yes, there might be an open enrollment, maybe here, now in the fall of the year, but if you don't bother to fill out the paperwork, they'll just re-enroll you for the next year. That's the same way that it works in the marketplaces, but no longer. Now you have to proactively fill out the paperwork again, just like now you have to fill out the paperwork in Medicaid now, not just every year, but every 6 months. They're doing that, so it's in both the Medicaid and in the marketplaces that there's these new bureaucracies, as well as if your income happens to change, which happens a lot for people who are lower income. Their income goes up and down if they're a seasonal worker, if they're a shift worker. And so this is, again, going to be a big deal with regard to, again, more ways that people fall off of coverage as a result. But the biggest impact in the marketplaces is the cost and the spiking premiums that are coming at the end of this year, at the end of December. Right now, again, there are these subsidies that are and tax credits that help you afford coverage, so you don't have to spend more than 1% of your income on a premium. There's a cap at 8.5% of your income, but for lower incomes, there's a sliding scale, so it can go down to 4% or 2% or even 0%. These are the result of some enhanced tax credits that were passed during the pandemic and have been extended a couple of times by Congress. But they set to expire at the end of the year. And if they do, folks in these marketplaces like healthcare.gov will see a premium increase of, on average, 75%. So in many cases, hundreds or even thousands of dollars. I'm going to get into that in a second, but I want to highlight a couple of other increases as well. Like, for example, back in Medicaid, for those in Medicaid. Again, these are people who are generally at or below the poverty level. This will increase cost sharing to be up to $35 a visit to see a doctor, which is a lot of money if you're at that income level. There's even those of us who have employer-based coverage, this bill creates greater exemptions for the prescription drug companies to allow the prescription drug companies to continue to have higher prices as a result of this law. And then there's other things in this law that if your income fluctuates, you will more likely to have a greater penalty at the end of the year to pay back more as a result of these tax credits. But I want to get really into the issue of the premium spike, because this is something that Congress is debating right now. In fact, if you hear that there's talk in this week about a potential government shutdown, this is one of the topics that's being discussed about it, which is, again, there is this spike that's going to happen, and the projection is that people will have increased coverage, increased premiums, and as a result, the Congressional Budget Office has estimated that about 4 million Americans will lose coverage as a result of those premium spikes. In many cases, so who are we talking about here? Who buys coverage as individuals? These are largely people who are working but don't get coverage from their employer. And so they are restaurant and retail workers. They're gig workers, like people who do Uber or Lyft or DoorDash. They're people who are independent, up and down the income spectrum. So they're just people who are independent contractors. So think musicians here in New Orleans. Think real estate agents. Think contractors. Literally Joe the plumber. Right, like people who just are small business people and the workers of small businesses, a shopkeeper, a barber, a barista. So these are people who are working but trying to buy coverage, and again, they get a tax credit that helps them afford coverage, but a lot of that tax credit is expiring at the end of the year, and so for young people, that could mean, let's say, I think we have an example of somebody here who maybe if somebody in their 40s making $30,000 a year, they could see an increase of $1,300. But the big news is for somebody who's in their 50s or 60s, because premiums go up in the individual market. If you buy coverage as an individual, they go up for people who have higher, who are older.
And it'll go even higher if that young person decides that's too much money and doesn't want to buy a health insurance.
Right. And so I just want to be clear that a 64-year-old couple making like $90,000 a year, right now they're capped at 8% of their income for the premiums. If that goes away, then they'll actually see a premium increase of $25,000. An increase on how much more they pay. So this is a big deal. So the average person on the exchange on the marketplace will see an increase of over $700 a year, but that average masks that if you happen to be in a high cost area, if you're older, you will have a premium increase of not just hundreds, but thousands of dollars. And admittedly, that's probably on the high end of scheme, but that's a very, very, very high end. So just to go back, I talked a little bit about the types of people who were impacted. And so in the big, beautiful bill, the whole point of it was to extend tax cuts that were imposed in the President Trump's first term, and to extend those tax cuts for now and make them permanent for the wealthy, for corporations, but they declined to extend this tax credit for working people trying to keep their coverage. There was multiple amendments to try to have this included in the bill, and they were rejected at many times. And Christina made a really important point. Even if you are not on the marketplaces specifically, or maybe you don't have one of those lower premiums, if people get a spike of hundreds or thousands of dollars in their premiums, a lot of them are going to fall off. And the people who are left are the people who need health care the most. So from the insurer's point of view, they're going to end up with a smaller and sicker pool of people to cover, which means premiums will go up. And we're seeing that in Louisiana, in states around the country, that after several years of single-digit increases in the base cost of health care, now we're seeing double-digit increases in the base cost of health care. And again, the premium tax credits would have shielded people from those increases, but now the loss of them means that people will feel the full brunt of those increases and actually make it worse. So this is a really important piece, and again, we'll talk at the end about actions, but this is something that Congress is literally debating right now, whether they prevent these tax credits from expiring at the end of the year, or people face those huge, eye-popping premium increases when open enrollment starts November 1. So this is a really big thing that I just appreciate us talking about. But so there, we talked about coverage, we talked about costs. Let's talk about the direct impacts on care, on the services that are provided by hospitals, doctors, clinics, etc. Christina?
Thank you, Anthony. Yes, so the impact on care, starting with the impact on providers and provider networks. A lot of significant changes in this law are actually going to happen behind the scenes in the form of Medicaid financing rules. So the big picture is that the law limits a state's ability to finance their own Medicaid programs. And the goal of that is that if we drive down the state share, you automatically going to reduce the amount the federal government has to match. And that's how state financing changes will trigger Medicaid cuts. So first, a bit about provider taxes. Every state, aside from Alaska, funds some of their Medicaid program through taxes on healthcare providers. And reliance on these provider taxes varies by state. It is a big thing here in Louisiana, and we know that provider taxes have been critical for helping states fund their Medicaid expansion programs. So under the law effective July 4th of this year, no states can impose any new provider taxes or increase any existing provider taxes. And beginning in the fiscal year of 2028, expansion states will have to cut down their existing taxes from a current limit of 6% down to the new limit of 3.5% at a rate of 0.5 percentage point a year. And one of the ways that states use provider taxes, and there's a number of ways, but one of the key ones is helping to fund state-directed payments. And state-directed payments are also unfortunately targeted by this law. So state-directed payments help states increase premiums for providers in the managed care program. And that helps attract providers, it helps ensure that they have a robust network of providers, and that really providers can keep their doors open. State-directed payments have become a crucial source of funding, particularly for those who work in services that are historically underfunded, like family planning services, like in hospitals, like behavioral health services. So in expansion states, the law caps these payments now at 100% of the Medicare rate. In non-expansion states, the cap is going to be 110% of the Medicare rate. I think Anthony's going to talk a little more specifically. Oh, okay, before we get to or do you want to move to the specifics of Louisiana, and then I'll go back?
Again, we talked about how this law has a particular impact in Louisiana. So these mechanisms to fund it, and this is the wonkiest part of the slide, trust me. But the key thing to take away is that this is how states help fund their Medicaid programs, and Louisiana is one of the ones who takes advantage of this the most, and so will be particularly impacted by this. Louisiana is one of two states that have that take advantage of two different revenue streams from provider taxes that will be impacted by this bill. And with regard to state-directed payments, again, Louisiana is one of the states that in particular uses as a mechanism to fund its Medicaid program. And so again, particularly impacted by it. And so this is in addition to the loss of coverage and the increased cost for consumers, this is a cut. And this will translate into a cut to providers and the like, because when the states deal with these reduced dollars, what are they going to do? If the Louisiana state legislature has reduced dollars, then they have to make cuts, and they have to make cuts to whether it's services or benefits or further cuts to eligibility, because at some level it's either that or cut other things or raise taxes. So there's going to be a set of things. There's going to be discussion in your state legislature about what additional cuts to make as a result of these, and a lot of that will fall onto whether it's hospitals or nursing homes or clinics, et cetera. And so then I think the thing that I wanted to point out is one of the groups that was particularly impacted by these cuts are the providers that have where Medicaid is the primary payer. And that tends to be maternity wards, that tends to be nursing homes, and it also tends to be rural hospitals. And there was a lot of discussion in the Congress about how badly this would impact rural hospitals. And they recognized that it was really bad, and so they tried to do something to deal with it. But Christina will say about how useful that is.
Spoiler alert, not very useful. So one of the things about this was the compromise, okay? $50 billion over 5 years. This is a temporary fund. The cuts in this law are permanent. So this does not go far enough. $50 billion seems like a lot of money, but it's roughly just 5% of the $1 trillion cuts to Medicaid. It is a drop in the bucket. Additionally, the administrator of CMS is going to have extensive discretion over almost every aspect of the program, including what applications look like, when the application period opens or closes. In fact, they just opened, I believe, last week, and how funds are allocated. And if states apply for funding and they don't receive it, there's no way for them to appeal that decision. It really gives so much power and discretion to the administrator of CMS. And in recent years, as Anthony spoke about a little, we've seen a lot of providers have to shut their doors because of budget shortfalls, especially maternity wards. In 2022, so really just before we've seen the full impact of Dobbs, 52%, so a majority of rural hospitals in the United States, no longer had a maternity ward. The National Partnership for Women and Families recently found that this law is going to place 140 rural hospital labor and delivery units nationwide at risk of closure. So I really just, again, want to uplift, this $50 billion is not enough, and right now states are scrambling for application, but even when those funds are distributed, it's going to be a drop in the bucket.
It's quite a truck. So you'll see some people touting this rural fund, but it's quite a trick to be saying, look at the money that we're giving, $50 billion here, while you're cutting $950 billion there. But so again, Louisiana should take advantage of the money, should apply for it, should get it, but just recognize that it's a fraction of what is being cut in the rest of the bill. And as a result, we will potentially see, just here in Louisiana, maybe 33 hospitals become much more financially vulnerable as a result of this law. Because again, this is a double whammy. Hospitals will be facing reduced, fewer paying patients, because coverage will go down, more uncompensated care. They very well will be seeing cuts directly because of state budget cuts, and other revenue streams will be cut off. And so that will really change the financing for some of these critical places, especially places that depend on Medicaid the most, like birthing centers, like rural hospitals, et cetera. And again, particularly here in Louisiana. But as much as we're talking about Louisiana as a state, we have to acknowledge that this bill this law actually specifically goes after specific populations in an even more harmful way, and Christina will talk about, especially for immigrants and for women and their reproductive health.
Yes, so unfortunately, one of the provisions of this law cuts off who is eligible for Medicaid.
Sorry.
So immigrants who will remain eligible for Medicaid are those who are lawful permanent residents or green card holders, certain Cuban and Haitian nationals, certain members of the Compact of Free Association. Newly locked out or ineligible for Medicaid will be immigrants who are asylees, refugees, victims of domestic violence and human trafficking, those with special immigrant visas. And as we've seen with a number of other provisions, this is going to really dramatically worsen health inequities. Confusion about who is eligible and fear of immigration consequences are going to keep even eligible individuals and immigrants from applying and from seeking health care. This is going to include the U.S. citizen children of immigrants who will now, studies show, probably be less likely to access care. There's also a number of other provisions that specifically target immigrants. So the law eliminates premium tax credit eligibility for recent legal immigrants who are not yet eligible for Medicaid benefits under the current 5-year bar under federal law. Another way that's going to increase uncompensated care costs is that starting in October of 2026, reimbursement for emergency-only Medicaid for immigrants is going to drop down. So as of now, if you are an immigrant who had been eligible for Medicaid expansion but for your immigration status, the state was receiving 90% matching funds from the federal government. That's going to be reduced to the state's regular amount of matching funds. So again, because obviously emergency care must be provided, we're going to see an increase in uncompensated care costs for hospitals. Another target of this is reproductive health clinics and those seeking reproductive health, which is honestly all of us. Effective upon passage, OBA blocks Medicaid funding for 1 year to any prohibited entity, which is defined as a 501c3 tax-exempt nonprofit, essential community provider that is primarily engaged in family planning services, reproductive health and related medical care, provides abortions beyond the very narrow height exceptions, and received over $800,000 in Medicaid expenditures for the fiscal year 2023. A prohibited entity must meet all 4 of these criteria. Additionally, in order to target all Planned Parenthood clinics, including those that don't perform abortions, the law defines entity as including all affiliates, subsidiaries, successors, and clinics. This provision very clearly was put in place to target Planned Parenthood. It does target a few other providers as well. Withholding Medicaid funds from these providers will force hundreds of vital clinics to close. There is no way around that. Thank you. Nearly half of women of reproductive age in this country live in what is deemed a healthcare shortage area, and almost half of all counties in this country have no OBGYN. The clinics impacted in particular serve underserved and rural communities. In fact, 76% of Planned Parenthood clinics are in such communities. And very recently, Planned Parenthood unfortunately announced that they will be closing their 2 remaining Louisiana locations on September 30th. Now, Planned Parenthood did sue. They were granted a preliminary injunction. Unfortunately, the First Circuit Court of Appeals recently stayed that injunction, meaning that as of right now, the services Planned Parenthood is providing to Medicaid enrollees, like cancer screenings, like contraceptive counseling, like HIV testing and treatment, they are not being reimbursed for those services. That is untenable. They cannot survive that way, and clinics will close and people will lose access to these essential preventative care clinics. Additionally, this is obviously not happening in a vacuum. We know that sexual and reproductive health has been under attack for decades in this country. Right now, there's so few clinics remaining, and this care is so important. In order to have a healthy pregnancy, you have to be able to time and space your pregnancies. In order to have a healthy pregnancy, you have to have access to preventative care. In order to have a healthy pregnancy, you have to have access to prenatal care. We are attacking the places that happens. That is only going to worsen maternal and infant mortality rates. So we just gave you a lot of really bad news, and now we're going to try to succinct it into even worse. What is the impact? As Anthony and I have been talking throughout, more uninsured folks. People are either going to fall off of Medicaid or refuse to buy within the marketplace because of increased premiums. That's going to lead to higher costs. We already know if the enhanced premium tax cuts expire, there will be higher marketplace premiums. But we've spoken about uncompensated care costs. We've talked about people with less coverage. That means that the entire healthcare infrastructure will be undermined and premiums will go up for everyone. More lawfully present immigrants will go uninsured and will be cut off from all other options. There will be fewer services for Medicaid and just fewer providers who can afford to stay within the Medicaid program. An increased uncompensated care costs means, as we've spoken about at length, hospital closures, clinic closures, and safety net providers closing their doors. What does this all mean for Medicaid enrollees? We've spoken a little bit about just how important federal financing is for Medicaid, and I just want to finish off by really uplifting that. Federal Medicaid funding comprises the largest source of federal funding for states. It finances just under 1/5 of state budgets. So coverage losses from these cuts means that states are going to have a really huge budget hole because they will be getting less federal funds. States are not going to be able to fill that gap. They're going to have to make some really difficult decisions. Within those decisions can be maybe cutting optional services, maybe cutting optional eligibility categories like postpartum care. really it's going to be a very difficult spot for them. They might have to lower or just keep stagnant reimbursement rates, which is only going to deepen our workforce shortages.
As Christina said, we offered a lot of bad news here, but I think the main message I want to convey to you is that these impacts are not inevitable. Yes, the law has passed, but the work isn't done. First of all, we need to both understand what's going on, but we need to build a backlash that allows us to re-envision and rebuild our health system in the way that we want it. These cuts are scheduled to happen, but if there's enough of an outroar, if there's enough of a pushback, they can be undone. And maybe it will be in this Congress, maybe it will be in a future Congress. There's some things like the premium tax credits that I just talked about. That's a fight that is a conversation that's happening in Congress right now. They declined to renew the expiration, but now there's a conversation about it in the context of funding the government. So that's a really important piece. So you can get engaged right now at this moment on an active debate about the premium tax credits. And then while we're talking about that, we should also be talking about the Medicaid cuts, the cuts to coverage. And I think it's really important to both, and to the extent that some harms are already starting to happen, we need to document that. We need to educate the community about what's going on. There's lots of cases in both state politics and at national politics where a bad policy was put in place, where cuts were put in place, and there was enough of a political backlash that folks undid it. And that's the work that we have to engage in over the next couple of weeks, the next couple of months, and frankly, the next couple of years. And so we need you that, to the extent that there are facilities that are closing, we need to spotlight that and talk about, or services that are being scaled back. We need to connect the dots so people understand why that's happening as a result of this passage of H.R. 1 and who voted for it and how that work can be undone. But I also want to spotlight something particular, which is that as much as there is a framework that is put forward, a federal framework, a lot of decisions will be left to the state to take action. So just on the work requirements that Christina was talking about, yes, every state, whether you're California or Louisiana, is now going to have to impose these new reporting requirements. But states will have some flexibility about how often should be the reporting requirement. Is it every 6 months or is it every month? What is the paperwork that you need to do to prove that? What are the exemptions that you take into account? Are you going to allow for electronic verification, like easy ways to check a box, or make people wait on the phone for 3 hours to fulfill their requirement? Like all of these things, and those things matter. We learned in the public health unwinding when people had to go through redeterminations of Medicaid, that even relatively small things like that have an impact of tens or hundreds of thousands of people getting or staying on coverage or dropping off of coverage. So this is an opportunity to engage at the state policy level to say, how are the states going to implement this? Are they going to do it in the easy way? Or are they going to do it in the hard way? And I think that if the states go in one direction or another, that could be the difference of literally across the country, millions of people keeping or losing coverage. So the fight isn't over, the work isn't done. And so, my main message is, we don't want whether millions of people keep or lose coverage to be left to an obscure regulatory process at a state agency. This needs to be a public effort, a public campaign. And so if there's the opportunity for public comment processes, we need to flood those comment processes with both organizational comments, but also individual testimonies of why that reporting requirement doesn't work for somebody who is a seasonal worker we need to do turnout, all of those things. So that's my main message. We're wrapping up. Here's the last thing, which is a specific action you can take right now, and there's a QR code to tell Congress these healthcare cuts are unacceptable. There's effort on our website on a whole section on lowering care costs now that's specifically about this premium tax credit and what people can do. And we hope that you take action to do that. Any last words from you?
I will
Yes.
quickly echo what Anthony has said. Whereas these harms are not inevitable, and the harms that are coming, we can do everything within our power to try to mitigate. These conversations are happening in state agencies and state legislatures now. How are we implementing work requirements? As Anthony said, make sure your voices are heard in those conversations. We want to make sure that everything is implemented in the least harmful way possible. We want to make sure that states are giving notice to enrollees and people applying for Medicaid, that those notices are appropriate, that they are accessible for all individuals, and that really we are communicating within our communities that these cuts are coming, and we must be mobilizing, and we must be helping those within our community. Story collection, as Anthony mentioned, is going to be so important. We need to know your stories. We need to hear your voices. We need to track coverage losses, closures. We have to evaluate outcomes as a result of those closures. And then we have to ensure that community members are receiving the education, and that we are doing robust community outreach and know your rights training so folks are not going to be hit by this unexpectedly. So thank you all for being here. You being here is a great start, and let's keep this conversation going. We are both from a national group, but we learn from our state advocates and our local advocates. We follow your lead. You all have been advocating and doing this for decades. We're here to help and support in any way we can.
And with that, thank you very much.
Let's give another round of applause for that very deep dive that really is helping us to know the work that we have cut out for us. Thank you so much for that. Right now, we have a welcome from our Congressman, who is also booting up to help us to fight this fight. And so if we can hear our word from Congressman Troy Carter.
Hi, I'm Congressman Troy Carter, and I proudly represent Louisiana's 2nd Congressional District. I'm honored to join you for Louisiana Center for Health Equity's Town Hall to discuss the disastrous impacts of Donald Trump's big, ugly law on every American. Everyday Americans feel this pain, especially here in Louisiana. Republicans are calling this bill a win, but in Louisiana, in our river parishes, coastal communities, and urban centers, we know better. Donald Trump's big, ugly law represents the largest cuts to health care and nutrition assistance in American history. This law slashes Medicaid, threatens critical flood protection and disaster response, and makes it harder for working families to access health care, housing, and higher education. It also threatens resources for our veterans, weakens support for people living with disabilities, and undermines our efforts to address environmental and climate challenges that directly affect the Gulf Coast. Families in Louisiana across the country will feel the real harm of these extreme cuts. Protecting life-saving programs like Medicaid and SNAP isn't about politics, it's about people. It's about standing up for affordable food assistance, strong hospitals, and resilient communities. That's why town halls like this one are so impactful. They represent a critically important opportunity to bring people together, to bring residents together, advocates, and local leaders to not only unpack what this legislation means for our great state, but how we can push back against it. I will continue fighting to protect our communities from the fallout of this big, ugly law, and will continue working to restore critical programs that dismantle the fight and the good things that we've had in our state that they're desperately fighting to take away. I want to extend a heartfelt thank you to the Louisiana Center for Health Equity and Dillard University for hosting this important conversation. I also want to give a huge congratulations to the Louisiana Center for Health Equity as you celebrate your 15th anniversary and the 10th anniversary of the Health Summit. Let's continue working to advance health equity, improve the well-being of our communities, and provide critical support for all of Louisiana families. Thank you all for your commitment, your passion, your hard work, and your determination to make sure that we do better, not worse, every single day. God bless you and continue doing the great work.
All right, excellent. So now I'm about to bring up our moderators. And I need y'all to get excited with me because they are a collection of amazing people. But let me just say this. If I were to share with you all of their accolades and experiences and just amazing things and ways that they've contributed to our community, it would take us quite a bit of time. So to the panelists, I'm gonna shorten our bio experience just a little bit, but we all know how dope y'all are, and everybody's gonna clap for y'all like I read the whole thing, right? Right, okay. So we're gonna start with Cary Goodman, the Program and Strategic Development Consultant for Balm and Gilead Healthy Churches Tour 2030. Give it up. The Southeast Diabetes Faith Initiative is a 6-state project designed to expand access and utilization of the National Diabetes Prevention Program and to create sustainable infrastructure within faith-based institutions. Thank you so much for that, Mr. Goodman. Next, we have Charles Stoecker, PhD. He is a health economist who helps figure out all kinds of things at Tulane University with vaccine policy, efficiency, air pollution regulation, and health insurance coverage on children's health. And in the new one, I saw something about Time Magazine, so I know that everybody recognizes your brilliance. So thank you for that. Now, our next person, Dr. Takeisha Davis, who is the CEO of the New Orleans East Hospital. I know very well because she grew up 2 blocks from me down the street. But let me tell you that she is an amazing woman who earned her Doctor of Medicine at Johns Hopkins and completed her pediatric residency at Children's Medical Center in Dallas. But she is put it down in New Orleans, both in the health department and with amazing community-based programming here in our city. Let's give it up for Dr. Davis. And Marcela Hernandez is a proud Latina social worker deeply committed to making meaningful and lasting impacts on society. She works with Families United in Action, FUA, and is really committed to grassroots organizing for resistance and popular education to create transformation. Let's please give it up for Marcela and the amazing work she does in our community. And we have Mr. Glenn Easter. Let's just say that Mr. Easter is going to tell us about himself, and we know that he went to Jackson State and that he puts it down for Phi Beta Sigma Fraternity Incorporated. Thank you. And let me just say, of all of the ones I read when I was Googling the bios, if I would have read Ms. Peggy A. Honora's, we could do a whole class just on Dr. Honore. She is the AmeriHealth Caritas General Russell Honore Endowed Professor at Louisiana State University Health Sciences Center. She works in public health epidemiology, population health programs, and at the School of Medicine, and is highly regarded as a prominent chief executive researcher and educator with a unique proven track record of accomplishments in private industry, healthcare, public health, and higher education. Please give it up for the incomparable Dr. Peggy Honore. So I was reminded that the LDH is currently taking public commentary. And so as we engage in this conversation with our amazing panel, please have your questions in mind and think of what you would like to make in comment, because as you heard, we're gonna have to come out strong with our voices, with our action, with our hands and our feet to make a difference in this. And so I thank you guys for helping to guide us here. So we're gonna start with kind of a big picture question that I'm gonna ask you all to respond to. From your perspective, what is the most significant way this bill will impact everyday people in Louisiana?
Good morning, everybody.
Good morning.
So, hearing all that was shared, I think from my perspective, and I work very closely with the faith community to address health disparities, and I think one of the biggest impacts or the most significant way that this bill would impact people is folks not really understanding. It's so much in the bill, and it's going to take some champions to really break it down almost to a second grade level, because it's so much, and then we have to also be very mindful that we're in a generation, we're in mixed generations, if you will. So some folks that were in the 50s and 60s, the way that they received information and processed it is so much different than those who are coming up today. So I think that's probably one of the biggest, most significant impacts, is that people just won't really understand. And so they will get cuts and are totally confused as to why they're getting cut.
So I think it would be really good to take a moment here, and we know these cuts are coming, and so let's appreciate where we've come so far. So I'm going to take a positive view and talk about all the benefits that we've seen from Medicaid in Louisiana. So we're part of a team, and it's kind of like a researcher's dream. Like any outcome you think of, Medicaid has probably affected it in a good way. So we've seen more providers in Louisiana accepting Medicaid because of this expansion. In consequence of that, we've seen that people have to drive less distance to get to their appointments. People report that they can afford to see a doctor, they can afford to take their meds better now that expansion has happened in Louisiana. Uncompensated care has gone down. That's you show up to the hospital, you don't have insurance, the hospital treats you anyway, and that's a loss that the hospital has to eat, or more accurately, that it passes on to the rest of us through our insurance. So Medicaid decreases that. Been fantastic. We've also seen impacts on people's personal finances. So payday loans are pretty predatory, super high interest rates. We see in the data that people take out less payday loans in Louisiana because of Medicaid expansion here. As a consequence to that, we see less people declaring bankruptcy. So many good things have happened about that, happened because of this. Now that's the positive angle. Now in the back of our heads, kind of the point of this bill is to take Medicaid away from a lot of people. So all the positive stuff that I just said, just reverse that, and that's what's going to happen.
I love that positive aspect of things, because when I walked up here, I was not feeling very positive. So I really appreciate that perspective. I think for me, the biggest impact that we will see from this bill, as we heard all of the data, is that more people will die from preventable health diseases, particularly Black and brown people, poor people, people that live in rural areas. You will not have access to safety net providers, whether they're rural hospitals or they're hospitals like the one I run. If you have a safety net provider that provides care to recipients of Medicaid over 50%, either we will be unstable and have to cut vital services, or we just will close and not exist. And so not only will you have people rolling off of the Medicaid enrollment rolls, but even if you have Medicaid, because of the instability that this bill will cause with the provider tackets, the directed payment program, the way in which we are able to provide that care, then there just will not be these healthcare institutions. And so what that means for us is that, particularly in New Orleans, so we're not just talking about rural centers, but our urban centers as well, where we already have a Black-white health life expectancy gap of 26 years. If you live in Lakeview, you live to 88 years old. If you live in New Orleans East, you live to 62 years old. That's just going to get greater. There's no New Orleans East Hospital, if there's no UMC Safety Net Hospital, if there's no Children's Hospital, those are hospitals that see predominantly patients who receive Medicaid. They are dependent on Medicaid funding, then we will see that gap continue to grow. We talk about women's health care. Black women in the state of Louisiana die at 4 times the rate of their white counterparts. If we have the closure of more labor and delivery units, because over 70% of deliveries are paid for by Medicaid in the state of Louisiana, that gap will widen. So I appreciate the positivity and want to look for the hope in us being here and being able to continue to fight for this, but we need to make sure that we are very clear in what will happen if we don't, and that is people will die.
Buenos días.
Buenos dias.
Once again, my name is Marcela Hernandez. I think one of the greatest impacts is an increase on poverty, and this, the way I see it, is an interchanging topic with health and poverty. And regardless of the population that you're working with, either if it's the Black community, the immigrant community, children with disabilities, I think poverty will have a direct impact in how our communities are going to be impacted. I also think that there is going to be a huge lack of access, not only in the healthcare system, but any other public assistance program that are out there, which will ultimately have a direct impact in our community's well-being, specifically our children. I have a great concern about our children. And I also think that this will have an impact on how our community perceives the system, and I think that our community will have an increase of fear to navigate in certain spaces and to really trust the system and to trust individuals that are supposed to be fighting for the well-being of our communities. And I think that the last and most important thing that this bill is going to have is that there are actually going to be legal pathways for discrimination, for racism, and also for injustices. The law is permitting that.
Good morning. I am an educator here in the city of New Orleans, and so I kind of want to bring it to an education standpoint at what I'm seeing actually as of today. A lot of students receive services that are paid through Medicaid, such as special education students, those students who receive physical therapy, occupational therapy services, speech therapy services, those social emotional services that they receive are paid through Medicaid. And as of right now, as an educator, I'm seeing that a lot of grants are being cut right now, and that gap is widening for those students who receive those services, especially those students we are trying to address with trauma concerns in homes and even at schools. And so without those services, again, that gap is just going to continue to widen and widen and widen. Trying to get students with those social emotional services, just reached out to some organizations last week, and the answers that I was getting is that we can't because we don't have the funding. We can't because the funding has been closed. We can't because there's no more money. There's nothing else that we can do. And so as an educator, we're saying, you know, how do we work with these students to address those traumatic concerns that they have? How do we work with those students who need those occupational therapy services? How do we work with those students where we have to go into the home because those students are homebound service students? And so that gap is going to continue to widen, and we say that we're very low in education. Well, we're just only going to continue to get lower and lower and lower without the Medicaid services.
Thank you. Just opening with a disclosure that I am here today representing as board president of the New Orleans Musician Assistance, the New Orleans Musicians Clinic and Assistance Foundation. So I'm not serving in my role as LSU professor today. This law is really going to have a significant impact on our population of patients at the New Orleans Musicians Clinic. We serve as a safety net provider for the musicians and cultural community. And every day I'm reminded that every premature death of a musician or traditional culture bearer is a lost opportunity for our rich cultural history to be preserved. And I really want to thank our moderator for mentioning in her opening remarks about how important health is to maintaining the culture. We have no culture if the population that we serve are not healthy. As someone said previously, loss of prevention services. That is so important in this cultural community. The loss of coverage and costs more. Our patients work in a gig economy, so they don't have stable work like others do. And if our American healthcare system is tied to your employer, they're left out from the beginning because the system is not set up to accommodate them with health care the way some of us are fortunate enough to receive.
Thank you for that. So on that note, Dr. Stoecker, we heard a lot about how the work requirements are going to change a lot. And we've seen some negative impacts from this in other places. How do you think it's going to play out for us here, particularly with this population that we're talking about, our very vulnerable cultural and gig workers?
So the interesting thing about work requirements is that other states have tried these, and at least one of those states has removed it. So you should think to yourself, oh, they thought it was a good idea, and then they decided it wasn't. So we've got a lot of research on what happened in Arkansas. So the kind of ostensible point of these work requirements is, oh, let's get more people into the workforce. We'll motivate them in order to keep their Medicaid. They now have to work. We don't see any increase in people working. And in fact, the point estimates are negative. So you might think to yourself, wait a minute, why would this work requirement cause people to work less? Well, when we look into the people who are disenrolled in Arkansas, 2/3 of them delayed their medications as a result of that. So there's a story that I want to tell you about Adrian McGonigal. So he was on Medicaid, and he was working at a chicken plant in Arkansas, and he was fulfilling the terms of the contract, right? He's on Medicaid, he's working, and he proves to the state of Arkansas that he is working, and he thinks he's done with it. What he doesn't realize is that he has to do it again and again and again. So the second time he doesn't prove it, and so they kick him off. So he spends a relatively short amount of time off, but in that time he can't afford his COPD meds. He gets sicker and sicker. Arkansas realizes their mistake and they put him back on Medicaid, but by then it's too late. He now is no longer healthy enough to work, and then he passes away. And so what's going to happen is people are going to lose their ability to afford care. They're going to get sicker, and it's going to lead to more expenses for us, and we're going to have a less productive resource because of that.
It almost seems like common sense, right? So, Marcela, when I think of the vulnerable communities, and I hear what Charles just said about reporting and these kinds of things, and we know how just the act of reporting makes immigrant families vulnerable. What do you think is going to happen in the context of this bill?
Well, I will say that my greatest concern, well, there are many concerns, but I think that my first concern is how the state of Louisiana is going to address language barriers. I can start speaking to you in Spanish right now, and I can assure you not even half of you can understand me. And if I'm requesting you to send an application, I don't think no one will be able to actually complete the application. And I'm not only speaking about Spanish language. I mean, we have a huge immigrant and refugee community in the state of Louisiana who speaks many languages, including indigenous languages. It's not only Spanish, so that's probably one of my biggest concerns. Of course, cultural competence as well, and how that will directly impact the ability of a person to actually apply for it. And what will be those limitations? know a lot of individuals that are coming from different indigenous communities who don't read or write in their own language. How are you going to expect parents to apply for Medicaid or any type of assistance for their children when they're not even able to speak, to write on their own language? I think our communities that are most vulnerable, you know, people with disabilities, children, immigrant children with disabilities, pregnant women, individuals that are, families that are mixed status families. And when I said mixed status, I'm talking about a family with US citizen children entitled to receive the services, but yet not able to do it because maybe one of the parents have a pending immigration status or TPS or DACA, whatever immigration status could be, and they will not be able to apply for them as well. So because of the household situation, then those requirements are not gonna be, they're not gonna be able to comply for those requirements. And then also our workers, who is out there working on that workforce. And I mean, we already know that their rights are constantly violated. And how are we going to ensure that the workers that are reconstructing our cities, are rebuilding our cities, are also going to be part of this conversation, which probably not. And also, I think talking about individuals who have domestic violence situations. I'm a social worker, and I'm always thinking about welfare and well-being. And I'm thinking about what is going to happen to our women that are confronting, you know, domestic violence or even abuse and neglect in their own homes. How are we as social workers will be able to advocate for children when we know that that type of advocacy can bring them into a path of deportation or any type of risk? So for me, it's more related to the complexity of our culture, our language, and who we really are as community. And I really would like to know what are the plans that they have, contingent plans for that.
Indeed. So speaking of planning for such a wide variety of groups with very deep needs, Dr. Davis, what challenges does this bill create for hospitals and providers as you attempt, and you know, we know your great work in trying to provide equity across populations. How is this going to complicate that for you?
I think, as we've heard, this is a very complex bill and will impact our communities in various ways. But as a provider of care who is always striving to tackle these health disparities, this is a setback for us. So as we think about, number one, the patients who walk through the doors, whether that's through the emergency room or our clinics, we have already started to experience, due to the unraveling of the public health provisions for Medicaid automatic enrollment, a lot of patients who don't know that they are disenrolled from Medicaid until they come to seek care. So we have seen over 250,000 people in the state of Louisiana disenrolled already because of that, before this bill's impacts. So the first place that it causes a challenge in the provider network is that now we have a larger number of uninsured patients. And so it's partnering with organizations, community groups to help to enroll patients in our facilities, right? Not come back, not get an appointment, but that you can go across the hall and get enrolled, right? How are we going to be able to staff that more, because we know we will have that. In the emergency department, listening to the presentation, the concern is there is retroactive Medicaid for emergencies that exists currently, but this bill is going to unravel that for certain populations. And so here again, we will have rules, federal rules that require us, and we want to make sure that we're taking care of patients during their emergencies, but there will be no reimbursement for that or coverage for it. So you have increase in uncompensated care that goes up for hospitals. And then, as I mentioned before, and we heard in our presentations, our hospitals, particularly in Louisiana, because we're so dependent on Medicaid, are very dependent on the directed payment program and this cost sharing with the federal government. So we have already started planning now in 2025 for what we think will happen come 2027, so that we don't have this huge decrease in funding. And we're talking about millions of dollars to already very fragile hospitals in Louisiana, where we have to see the closure and cessation of services, or hospitals in general. As we speak today, we have 9 rural hospitals in Louisiana at present that are very fragile. And so these changes will lead, if not dispense appropriately, to their closure. And so as we think about the impact to the safety net providers from the patient aspect and the provider standpoint, it is concerning. I did want to remark upon the Rural Transformation Fund too, and I love the way it was presented. You know, we keep hearing there's this $50 billion windfall that will come to all the states, and forgetting that they're taking away $950 billion out of our system. But it is a place, as we just heard, that our state will have a lot of flexibility in how that money is actually allocated to hospitals. So federal government and CMS has a lot of flexibility and determination on how it gets distributed to states, but our state will have to determine who will receive those funds, how and where. Even though it is a temporary fix, it is one that will allow us, hopefully, to cover the gap until we vote in a new Congress that can repeal this bill.
Ashe. So, Dr. Honore, I want to shift to you because what I've heard on the stage so far, you know, is a lot of immediate need, and then we're going to have, you know, this big overarching long-term goals that we're still trying to reach, like, you know, lessening this 25 to 30-year disparity between Black and white New Orleanians in terms of their life expectancy. So how do we balance that fight, you know, against those harmful policies with immediate impacts, and building that bigger, more equitable system that we want to see here in our city and our state?
In order to build this more equitable system that we know we all need, I mean, we didn't have it now, we're not going to have it after the law. It simply cannot happen with things that have been passed into law. It's very important that we get very active in addressing this. Just in the musician and culture bearer population that we serve, 48% of our population is on Medicaid, with anticipated severe reduction in that population being eligible for Medicaid. As an example, before Medicaid expansion, 56% of our population was uninsured. With Medicaid expansion, we got that down to only 20% of them being uninsured, with 48% of them being in Medicaid. The strategies that were put into place to get us to be able to serve more people, to be more equitable in the care that we provided, that's all going away. There's going to be a significant amount of people that are going to lose Medicaid and who are going to be uninsured. As an example, with the premium increase example for the marketplace plans, our best case scenario that we're coming up with is that we're going to have 165% increase in premiums. So a person who would be paying $58 that's going to go up to like $178. And these are gig workers who are going to have reductions in the services available to them or, cut out completely. So how can we talk about equity when people are going to lose coverage?
Mm-hmm.
I mean, there's no comparison. It's just not, it's not going to be an equitable system if something is not done to improve upon what this law has given us.
Ashe, and it seems like the things that can be done are, if not limited, they don't seem to have a wide lane of action, right? So Reverend Goodman, I want to ask you, how might faith-based and community-based organizations, how might we take a part in this? How can we buffer some of the impacts that you're hearing about?
Yeah, so I think one of the most important things is to speak truth to power. Call it what it is, like for real. But most importantly, act as trusted messengers. I think that's powerful because, again, one thing that she mentioned about the language barrier. Those of us who may speak medical language, those of us that may speak policy language, is not the same for someone who's sitting in our pews or in our communities or may have a strong language barrier. So I think that's super important. So be on the forefront of education so that those people that you feel may not know. Let's be real. Everybody that's sitting in here, we've heard all of the words, we've heard everything that they presented. Was it Christina and Anthony? We heard everything that they presented, but even some of us sitting in here are still clueless as to what's going on. So we need to make sure that we are our brother's keeper. We need to make sure that we are making sure that our families understand what's going on. We need to advocate for those people that may not speak the same language. If there's something that's presented to somebody and it's English, but English is not their first language, then we may need to say, hey, let's translate this for somebody else because they may need it. And we need to help each other navigate the complexity of this. I appreciate Charles for his positivity, but the reality is we need to appreciate the negativity as well because it will impact each and every one of us. So that's probably the most important thing. But faith communities, you are places of spiritual care, but also you are places of community. And I think that's super important. Even our community organizations, we need to make sure that we are holding firm to the communities that we say that we are building and identify resources, because if something goes away, then we need something else to stand in the gap for it.
That's right. Ashe, thank you.
And we have to be very clear about that. If you need $5 and I have 10, guess what? I'm going to make sure you have what you need to get everything that you need.
Thank you for that. And I want to give a shout out to the work that you do with community health workers and those trusted messengers to actually build the relationship between the policy and the actual work. I participate with such a thing with New Orleans East Hospital, Dr. Davis. I deserve it. Y'all check us out. But one of the things that those community health workers need, right, because they got this part, they have the community part. Sometimes we need help in the analysis on what to attack first. So I want to ask Mr. Easter, you know, as we're looking at this, because you gave us a great insight like around the education and how it's impacting that stuff. What are the parts of this that we can work to improve? The parts of the big, beautiful bill that, you know, if you were recommending to community-based groups to hone in on, to say, we're going to attack this first and this is where we can make the change. What do you think?
Before I go and answer that question, I just kind of want to rewind just a little bit, and then I'll go into that. I just kind of want to speak to a little bit of what Ms. Hernandez spoke about the fear in the families that the immigrant families that we have. I've worked in the city for about 2 decades now, and the schools that I've worked at have large immigrant populations. And so today, because of the fear, we have students that are immigrant students in high school who are at a kindergarten level. Their families are at a kindergarten level. And so when these students qualify for those special education services, families are afraid to come into the school to even sign to give consent because, number one, they even though we're sitting across from them and we're explaining to them, they still really don't understand what they're signing. And we're letting them know this is to support your child's education. They don't even want to come to the school for fear if they feel like they come to the school, ICE is going to be right there on the corner to get them. So these students are not receiving the services that they could be receiving because of that fear. Also, another thing that's happening in education as it comes to our immigrant population is that those immigrant students take a test, just like the LEAP test I'm sure you all are familiar with. They take what they call the EL test. The state has changed the scores for those EL students and has made it a lot more rigorous for those students to pass those tests. And so what happens is now that is starting to impact the school's performance score. And you know, schools here in New Orleans, we always pay attention to A, B, C, D, F schools. And so now because we have these schools with the large immigrant population, the scores have changed, they've become a lot more rigorous. Now, when the two students take the test, what's going to happen? The school is not going to meet half the time the performance score. So they look at doing what? Closing those schools. Education is doing what? It's growing wider and wider and wider because of what they're doing to immigrant populations. And also our black and brown students, the exact same thing. They are widening the test scores so that these schools that are being serviced in the East or, you know, they're trying to close those schools. So what's going to happen to those students and families out in the East or out in Michoud where there's only 1 or 2 or 3 schools that are servicing those populations? But to answer your question is to really build community trust. I think that's really, really what we need. Those black and brown families, those immigrant families need to know that there is a community here to support you and your well-being.
Can we all give it up for our amazing panel who infuse us with urgency, with knowledge, and with the inspiration to go on to do some great things for our people when we walk out these doors. I think we all have been voluntold that the charge now belongs to us. So Mr. Glenn Easter, our great panelist, is going to come on up and give us a call to action right here at this stage while we clap our panelists back to this.
All right, good afternoon. Thank you so much, panelists, and for having me to do the call of action. So as we've heard today how this bill risks deepening the barriers to care for our most vulnerable neighbors, the takeaway is clear. We cannot afford to be passive Each of us has a role, whether it's educating our communities, amplifying our stories, engaging policy workers, or supporting organizations on the front line. Let's leave here committed and turning concern into action and action into change. Louisiana families deserve nothing but the best. As a challenge, I ask you to do 3 things when you leave here today. Share what you've learned. Call or write your elected officials and support groups like LCHE and other community organizations. Thank you very much.
We would like to thank all of our speakers, all of the people who participated today, along with our moderator, and thank you all for taking the first step, the first action step in attending and being here at this town hall. We thank all of our volunteers and everyone for being here, and hopefully we will see you again. Thank you.